Good evening, everybody. Nice to meet you all. I think there's some familiar faces in the audience and lots of names that I recognize from referrals and collaborations from the world of PANDAS, which is amazing. And isn't it amazing how just how quickly this field has grown? I mean, over the past 5 or 6 years, how we are making big advances, not just in treatment, but also the political movements behind getting PANDAS recognised and getting treatment for our patients. I think it's phenomenal. So first of all, thank you for being so brave and brave enough to treat our patients, because I think it's not easy to treat patients in this arena when you know the vulnerabilities that we have, bearing in mind the politics that there are around. But I think there's a real shift. And that shift has been much more evident over the past 12 months. Now, because I'm with a group of professionals that I think know a lot about PANDAS, I'm going to whiz through the things that I think you'll know already and not focus on them. But please feel free to ask me any questions at the end. And what I'm going to focus on is basically what we're talking about in the international meetings. So over the last 5 or 6 months, there's been big presentations. First in Boston, where the Alex Manfield Fund is based, and those of you that know anything about Alex Manfield will know that Alex Manfield was a 26-year-old patient with PANDAS who unfortunately took her life as a result of the disease process, and it's a very sad story. But her parents, she was an only child, and her parents have made it their mission in life to make sure that no other child dies of this condition. And as a result of that, they coordinate a very, very interesting and probably one of the major meetings for PANDAS every year, which occurs in every other year, which occurs in Boston. And the plan is to bring that meeting to Europe, so that we do the US one year and then probably France on alternate years, maybe from next year onwards. And there's a lot of good stuff that happens at that meeting and a lot of sharing of information. So what I wanted to do today was just talk about some of that data and how we've put it together and what we think is happening, and then we can discuss where we go from here and also answer any questions. So, and I'm going to, obviously, I think I'm talking to mainly people in the arena of nutrition and functional medicine. But if anybody wants me to take a slightly different slant on it and wants to ask me any sort of conventional questions about immunology or neuropsychiatry, I'm happy to take those as well. Right, so to start with, I'm going to just share some slides with you, and then we will go through the talk. Okay, so you should now be able to see my slides. So the first thing is I need to just let you know about my disclosures. So as Gillian said, I set up the Children's eHospital. That was many, many years ago now. And we became sort of fully functional around about 2017 with a real focus on PANDAS. And then in August last year, we decided to make a full commitment to the work of PANDAS. So we have the London PANS Clinic and Research Centre, which is where we're focusing on getting the evidence, the UK evidence for the treatment of these children, the assessment and the treatment of these children. So I run both of those. I'm also a member of the UK PANDAS Physician Network, which is actually a group that's been put on hold whilst we focus on the development of guidelines and look at the political aspects of PANDAS within the UK. And I noticed that Georgia Tucky's on the online today, and Georgia did a lot of work with the parent groups as CEO of PANDAS UK. And laid the foundations for the work that's going on now. So thank you, Georgia, for all of that work that you did in the past. And really, that political work is the thing that's really driving the process now. I'm also a member of the European Neuroimmunopsychiatric Association, And that is, again, much more research based, and we're looking to develop studies in conjunction with Erasmus University. And we hope to have our very first PhD student with the London PANS Clinic and Erasmus University looking at a project specifically on PANDAS. As far as I know, that would be the first UK PhD student looking at PANDAS. So that should be launched imminently. And I'm also part of the UK PANDAS working group, which has got representation from all the main Royal Colleges looking at guideline development. Okay, so you'll probably all know the diagnostic criteria for PANS. An abrupt, we used to say an abrupt onset of things like obsessive compulsive disorders or restricted food intake, and other features including anxiety, emotional ability, and others. I'm not going to spend much time on this. However, we're moving away from abrupts now, because there is clearly, as we treat more and more patients, there's clearly a group of patients where the onset is more insidious. Similarly, with PANDAS, we look at the onset of compulsions, of tics, and the JCAP guidelines, again, describe this as abrupt, but as with PANS, we're moving away from that. And I think by the end of this, what I hope to put forward is a suggestion that PANS and PANDAS are probably the same thing. Okay, and the main symptoms that we look at are tics, OCD, anxiety, urinary symptoms, which we see in 50% of patients, eating disorder, misophonia, and a few other things that as we treat more patients, we are beginning to start to see and think about, and that includes visual disturbance, processing disorders, which are a little bit unusual and not explained in the usual ways, and joint problems or arthritis. So, what we have, the issue around PANDAS is that it is not a condition that sits very well in one speciality. So when we have a patient presenting with symptoms and signs of PANDAS, we have to remember how that patient is viewed depending upon the speciality that they first encounter. So if you have a child with sudden onset of OCD and tics and they see a psychiatrist, the psychiatrist will view that patient through the psychiatric lens, and that is completely understandable. A neurologist will look at it in a slightly different way, and a rheumatologist similarly in another way. So a child who presents to general practice may be classified as having something like a behavioural disturbance. A child that presents to a general paediatrician may be considered to have the onset of autism. And a psychiatrist may look for evidence of trauma in the child's past, and a neurologist will, of course, want to do an MRI scan and an EEG. I think you get the point. The point is that each of these specialities will look at the child in a particular way. And what we've got to remember is that PANDAS crosses specialty boundaries. It is, however, a post-streptococcal phenomenon, and this is not necessarily saying that other infections aren't important, but the evidence suggests that both PANS and PANDAS is now a post-strep phenomenon, and but other infections can have an impact on how it presents itself. And when I show you the unification hypothesis at the end of this talk, hopefully this will make a bit more sense. The importance of this graph is just to demonstrate that actually, when you get a first exposure to group A strep, you generate antibodies, and the antibody proxies that we have available to measure in the UK include the ASOT and the anti-DNase B. And you'll see that these antibodies start at 0 and then reach a peak with the ASOT, for example, at 2 to 4 weeks, and then gradually come down. But they don't come down to 0. Okay, and that's the important thing here. You've always got antibodies that are present in the circulation, and that's the basis of immunity. When you if you do a blood test and the ASOT is less than 200, it doesn't mean that there isn't antibodies there. It just means the antibodies are low. But the antibody receptor relationship, which we think is important in PANDAS, means that even a low level of antibodies can cause symptoms. Okay? Okay. The next bit to consider is the blood-brain barrier, because actually, if you look at a normal brain and you look at the way that the vascular system is supplied to the brain, antibodies shouldn't be able to get access to the brain, right? So the blood-brain barrier normally protects the brain from attack from antibodies and also from other harmful agents, including chemicals, and that includes drugs. So what is the blood-brain barrier? Well, if you look at the area in the middle, that shows you one of the blood vessels. And then the cells that surround it are cells that comprise these are elements of the immune system. And what they effectively do is create a ring of defense to prevent elements within the vascular system from leaving and attacking the brain. And this is the pivotal part based on the most recent research, which has come out of Stanford. Not yet published, but this is work done by Mondale, which should be published this year. And he's part of Jenny Frankovich's team, which shows that the blood-brain barrier in PANDAS patients breaks down in the region of the basal ganglia. And that's very important. And it looks like that process is mediated by an enzyme called MMP9, matrix metalloproteinase 9. And it's that allows gaps to occur in this ring of defense, which then allows antibodies to gain access to the basal ganglia and cause the problem. Okay, so that's the issue. So this is a section through the brain, and there's the level of the slice is shown in the top left, so it's a horizontal slice. And the bits in blue, in light blue, are the basal ganglia, and those are important for tics and obviously and also OCD symptoms, and that's where much of the work, and for example, with Tourette syndrome has been focused on the lentiform nucleus. And these are the areas that become dysregulated and where the blood-brain barrier breaks down. There is, however, another area which is very important, and it looks insignificant, but it's important. And that's this little red line called the claustrum. Now, this is my hypothesis. So this is, it's very difficult to investigate the claustrum and to because it's tissue paper thin. But in 2005, Francis Crick, who was one of the people that was involved in discovering the DNA helix, was writing a paper on the claustrum, and he described the claustrum as the seat of consciousness. And the reason for that is that this tissue paper thin part of the brain is widely connected. It links together all the different parts of the brain. And the way that I describe this is it's a bit like the computer chip in your brain, right? It's the processing part. And it's connected with the insula, which is where the sensory inputs come in, and then it has both an input and an output function. So for me, the claustrum is the bit that allows us to understand why children get dysregulated in a particular way, why some of them get non-epileptiform seizure activity, why they lose consciousness. Okay, so this is the bit that I think is really very interesting. And if you think of it as a computer chip, you'll understand that even with a normal computer, you have that balance of the ability to have a certain amount of input, but if you overload the computer chip, then it freezes and you get your little beach ball on your screen. And that's actually what happens in some of these patients. They literally stop processing effectively and they freeze. And that's when the seizure activity occurs. And that tends to occur in the older patients. So when we've now seen somewhere between 1,400 and 1,500 patients with PANDAS. So, and we've got a lot of experience with those patients on the peripheral part of the normal distribution curve. So those patients that act a little bit unusually. And quite often they will get a diagnosis of either autism, Tourette's, or FND. However, if you start to investigate them and you look for the dysregulation of their physiology, you can normally work out what it is that's going on. So if we are going to focus in on the basal ganglia and think about how it all fits together, let's look at the mechanism. So here is the brain with the basal ganglia protected by the blood-brain barrier in peach. But when you get a significant inflammatory infection, you get a rise in MMP9, which is the enzyme, and that dissolves the blood-brain barrier. And that allows the antibodies to then access the basal ganglia, which then overwhelms the claustrum. The claustrum becomes dysregulated, and you get this concept of what we call neuroinflammation, and that results in the symptoms that we see in these patients. And the major symptoms that we see are the tics and the OCD, which we see in about 75 to 80% of the patients. And then you get dysregulation of certain senses, particularly sound, misophonia, but also other senses, including vision, POTS, dysautonomia, urinary symptoms, eating disorders and anxiety, all of those things that we described in the definitions. And some of the older patients will get seizures and dystonias. And then to treat it, what we need to do, we have two main strategies. One is reduce the antibody load, and the second is reduce the inflammation. And I think that you guys will be more interested in reducing inflammation. But if you do that, you then allow the blood-brain barrier to reform, and that reduces the access to the basal ganglia for the antibodies. And over time, the antibody levels will then fall, and you will get a reduction in the symptoms. And with most patients, we achieve, with the first round of treatment, somewhere between the region of 70 and 80% symptom improvement. So fairly significant. So, but there is a pro-inflammatory process in here within all of this. So that pro-inflammatory process is, first of all, the group A strep infection. But also, once you've had a group A strep infection, remember that even if you've recovered from it, you've still got those antibodies present. And therefore, any other infection which has a strong inflammatory effect will result in the breakdown of the blood-brain barrier. So COVID, influenza, chickenpox, those are the big ones that I don't like because they're so inflammatory, and they will then allow access to the brain with these antibodies, which achieve their effects because of the concept of molecular mimicry. Looking at the cytokines that are involved in those pathways, interleukin-1 beta, interleukin-17, and TNF-alpha are the ones that cause upregulation of MMP9 during a group A strep infection and or other infections, and that's what causes the blood-brain barrier disruption, which then results in the neuroinflammation. And when we look at the response to treatment, one of the things that puzzled me was you'd get parents who would say, after the second or third dose of ibuprofen, that the child's symptoms improved. And you know, from a purely inflammatory pathway effect, you would say, well, you know, that's a bit unusual. You know, how does that work? How does that work? But actually, if we now think about MMP9 and you look at how quickly ibuprofen works on the COX pathways, it actually makes complete sense. So with ibuprofen, you would start to see an impact between 1 and 2 days, a peak effect. Antibiotics 10 to 14 days, that's what we see. Steroids 3 to 4 weeks, again, that's what we see. And PEA I've thrown in here because this was something that Lucinda Miller introduced me to many years ago. And I think it just gives that extra boost in patients when you've given them all the standard medical treatments, and just gives you maybe an extra 5% of symptom improvement, which can make a big difference to a child. So, so the 5-point hypothesis, I took this slide from a post that I did earlier on, so I did it very quickly, so I apologize for the picture. But essentially, there are 5 points in this 5-point hypothesis. First of all, you need to have genetic predisposition to group A strep and PANDAS, because the antibody that's produced has to be able to recognize the receptors in the brain, and those receptors are cholinergic interneurons. You need to have a history of group A strep infection at some point in the past. It doesn't need to be the primary event when you first see the patient. And then you have to have breakdown of the blood-brain barrier. the activation of the cholinergic interneurons, and then that, I think, results in claustrum dysregulation, which is where all the sensory problems arise. The treatments that we have available include antibiotics, anti-inflammatories, and steroids, which will have an impact in terms of the antibiotics will have an impact on reducing the antibody load, but they'll also have an impact on the blood-brain barrier, as I've already described, together with anti-inflammatories and steroids. And then we have other ways where we can reduce the antibody load, including IVIG, which works very quickly. But remember that if you give IVIG, although your antibodies will go down to zero very quickly very quickly after being administered, that your body is designed to produce those antibodies again. So your B cells will start to regenerate antibodies, and you'll come back up to your immune level, which may be 100, it may be 200. It will be low, but it will still be there.